Thank you for that introduction. So my background is I am a social worker by training, which sometimes surprises folks when they hear I'm going to talk about cognitive assessment and interdisciplinary teams. But I actually do a ton of cognitive screening, cognitive assessments as part of my role with SLU. We have a number of clinics where we see folks directly who have suspected memory issues, and we coordinate a lot of care through our SLU Hospital University care team in terms of making sure that folks are seen by neurologists, neuropsychiatrists, so that they can get kind of the whole scope of the diagnosis taken care of. A lot of my research is focused on folks who live alone with Alzheimer's. So I also see a lot of folks out in the community who may have some suspected memory issues. They may or may not have a care partner. And oftentimes I'm seeing them at a point of crisis when they're interacting with emergency services. That has been how I've been able to facilitate some of that research to date. So I bring that in terms of some of the perspective in our discussion today. Real quick, just some of the disclosures. I have had some funding, royalties from Springer for a book, and then some of the work that I do with the Alzheimer's Association. Today's presentation is going to talk just a little bit about some of the different diagnostic criteria and classifications of dementia. I'm going to be real light on this just because I saw that we have Dr. Lane speaking a little later today about differential diagnosis. And so I don't want to take too much away from that presentation. I think that'll be a much more in-depth, richer discussion. But we will talk a little bit about some of the key components of comprehensive dementia assessment, what all that entails, some of the different interdisciplinary roles that can contribute as part of not only assessment, but then what does the care and treatment look like once an individual is diagnosed. And I will review a number of the cognitive screening tools that we've even already been introduced to today. So we'll talk a little bit about MMSE, the MOCA, the SLUMS, St. Louis University. I have to talk about SLUMS, but I'll also talk about the clinical dementia rating, the CDR, and the FAST assessment as well, just so that folks have some familiarity with that and can recognize some of those different screening tools as you come across them. We'll also, just in general, kind of talk about the importance of some of that interdisciplinary collaboration and ensuring that folks get the care and treatment that they need with their new diagnosis. So to get us started, I think it's no surprise to just kind of talk briefly about why it's important to have folks receive a diagnosis and ensure that we can get them started on treatment, despite the fact that we don't currently have a cure for some of these dementia and Alzheimer's disease diagnoses. Without a diagnosis, folks can continue to experience things like functional decline, morbidity, mortality, more likely to experience things like hospitalizations without, enough of an explanation of what's really kind of going on here. And it's not uncommon for folks to be subjected to kind of premature institutionalization, where they may have to go into a facility maybe earlier than they would have if they had been maybe engaged with some interdisciplinary care and receiving some of the available medications that we do have that can support folks that are living with some type of cognitive decline. We also know that diagnosis can improve cognitive, physical, and social functioning for folks. Oftentimes when I encounter folks and we talk about a diagnosis that they've just received, I'll often hear from folks that even though they were very fearful of the diagnosis, dementia is still the most feared diagnosis among folks over the age of 65. Folks will say that they're relieved. They recognize some positive aspects that come out of having that diagnosis, even though it is disappointing sometimes to hear that, and folks can still be in denial after they get that diagnosis. But a lot of times folks are eager to learn, what can I do now that I know that I have this diagnosis? What are proactive things that I can do? What are things that I should engage in? Are there, medications that I can take that can help with some of the symptoms? And so oftentimes after that initial diagnosis, we really want to talk with folks, to determine appropriate management strategies. It's going to continue to decline. It's a terminal illness, but what can we do for folks to really kind of empower them, give them some hope, give them something that can maybe help them connect to others that are going through the same experience. I think because of how the cognitive assessment process kind of goes for folks, a lot of times it tends to be very fractured. And so folks might get a cognitive screening here that's concerning, and then they get a referral and they might see their primary care doctor that then refers them to another doctor. And it's kind of a process for a lot of folks that many times folks don't actually get an actual diagnosis. I encounter a lot of folks that will come to me and say, well, I was prescribed, donepezil, Aricept. It says in my billing that I'm being billed for dementia, but nobody's actually come and told me that I have this diagnosis. And I think that's partly because of kind of the fractured approach that we have in terms of getting folks that diagnosis. And I think it's also, too, we're, of course, as providers, very hesitant to give someone a diagnosis until we feel more confident that we are for sure that is really what's going on. We can differentiate. It isn't just dementia, but we think it's Alzheimer's disease. We think it's vascular dementia. We think it's Lewy body. We want to be able to kind of give them the full information, the full picture. And so sometimes that initial conversation about there are some concerns here doesn't actually happen. And as you can imagine, that can be really challenging for folks. They may not seek out supports or resources beyond just that initial prescription that could be really meaningful and help them in other aspects of their health and well-being. So an encouragement that even if you're kind of suspecting that this may be what's going on, folks want to know, and they're eager to kind of hear some of that. We've talked already a little bit about the difference between dementia and MCI. And so just as kind of a reminder as we gear into this conversation, MCI is kind of that intermediate stage between being cognitively normal and starting to experience some cognitive decline. If folks are having more kind of memory loss and they're screening in at that kind of MCI category, they may be more likely to have amnestic MCI. And research is a bit mixed in terms of, does everyone that always has MCI go on to progress dementia? We have studies that kind of say different things. But for that amnestic MCI, it does seem more common for folks to go on and progress into a form of dementia after initially having some MCI. So important to let folks know about that MCI diagnosis. What does that mean? But also to, link them in with resources and support that can help kind of guide them into maybe being involved in some advanced care planning, maybe getting connected in with some peers. We're in an era now where a lot of folks are doing that online. There's programs like Dementia Minds that runs support groups for folks online. There's Alzheimer's Association offers some early stage programming in certain parts of the country. So there may be ways for folks, even if they're kind of more geographically isolated from some services, that they can still participate if they can get online. Of course, we know that dementia is quite prevalent. Over 6 million are living with it here in the United States. And within that, Alzheimer's disease tends to be the more common type of dementia. It's probably why it has the name association, the recognition, is because it accounts for the majority of dementia cases. Other types of dementia, researchers will debate in terms of all of the different kind of classifications. There's thought to be somewhere between 40 to 50 different types of dementia. But the big ones we tend to see more frequently are vascular dementia, Lewy body dementia or dementia with Lewy bodies, and then frontotemporal dementia is another big one. More and more in kind of the clinical settings, we're starting to also see a lot of diagnoses of mixed dementia, where folks may have more than one type of dementia going on at the same time. Right now with diagnosis, there's no single test that can really kind of define whether or not somebody has a certain type of diagnosis. Historically, folks have had to wait until autopsy to be able to really confirm whether or not, a case was Alzheimer's disease. And I think with more of the differential diagnosis and some of the imaging tools and skills of professionals in terms of being familiar with what to look for with differential diagnosis, we are getting much more accurate in being able to diagnose folks and diagnose them accurately with a differential type of dementia. Blood tests are coming. We have seen a number of tests that may be able to help determine whether or not an individual has Alzheimer's. Currently, you can go to Quest. Quest came out this last year with a consumer-initiated Alzheimer's test where you can test to see if you have the genes that are more frequently associated with Alzheimer's disease. Now, before I encourage my patients to go do that, we do talk a little bit about what that means and educate a little bit about what could be some implications of having that type of information. But it is something that folks can go and have ordered from the lab if that is something that is of interest and they want to know that information. It's not uncommon for folks to have some difficulty in diagnosing the specific type of dementia. We're still kind of fine-tuning the process and really kind of nailing it correctly. It is not uncommon. I've heard from a number of families that their dementia diagnosis has changed over time. So they may have been initially told that they suspected it was Alzheimer's disease, but now they're thinking that it may actually be more of a mixed dementia. And so that's not uncommon as, again, we continue to advance our brain imaging and skills and training, but then also to for folks as we kind of have a more longitudinal picture of what's really happening for folks. The more kind of time points we have to look at, the more we can really gauge and tell from it. It's not uncommon for folks to get a cognitive screening in different settings. Maybe that's a primary care doctor's office. Maybe that's at some type of geriatric clinic. Maybe with a geriatrician, and then a lot of times folks will be referred to either a neuropsychiatrist or a neurologist so that we can have some additional kind of either cognitive testing done or imaging done. As a social worker, I really kind of work within the operations of the diagnostic criteria from the DSM-5. DSM-5-TR just recently came out. But essentially, the criteria that we're kind of looking at when we're kind of initiating a cognitive screening and really thinking, is this something where an individual may need to be referred? Do we need to link them back in with kind of the next stage of testing? We're looking at the following DSM criteria. So we're looking at memory impairment. Are they have an impaired ability to learn new information? Are they having difficulty recalling old information? We're also looking, is there a language disturbance with aphasia taking place? Is apraxia happening with some impaired motor functioning? And is there any kind of disturbance within executive functioning? That's probably the one we see most frequently with folks, at least out in the field. That's the impaired ability to plan, organize, sequence, abstract, problem solve. And that tends to very much accompany some of those dementia diagnoses like Alzheimer's disease. We also look at how that cognitive deficit affects folks kind of in their day-to-day life. So does it impact how they engage in social interactions or within their occupation? Of course, folks 65 and older may be less likely to still be working, but they may still be involved in other kind of settings within their community. So sometimes that's asking about maybe a volunteer role that they hold within a church setting. Maybe that's speaking with them about maybe they typically host the family Thanksgiving. How has that become maybe different or more challenging? And talking about how that changes maybe occurred. Dr. Heiner talked a lot in her previous presentation about having conversations with folks. And so this is the kind of dialogue, as you're getting in, you're starting to talk with folks, you're getting to know them and what their situation is. A lot of times, either they're initiating, they have concerns about their memory, and that's what's prompted them to want to get a screening done. Or maybe somebody else in their life has prompted them. Maybe it's a partner, maybe it's an adult child, maybe it's the next door neighbor. I get a lot of neighbor referrals looking at folks that live alone, where they have some concerns where they're just noticing that the individual is having more difficulty with things. We also have to rule out other explanations. So making sure that it's not delirium and that it's not due to another kind of medical or psychiatric condition. So those diagnosis components, again, we try to kind of keep those together, keep everybody kind of informed and aligned with kind of sharing information among parties as long as we are HIPAA approved to do so. But we are essentially kind of looking at that cognitive testing. We're going to talk about cognitive screenings here in just a minute. We can also look at things like functional assessments. So this is, folks' mobility, their ability to kind of do things independently, get dressed, bathe, those sorts of things, make a phone call, manage their finances. Behavioral observation most frequently comes through the use of a care partner. So asking about what kind of things have you noticed in terms of symptoms of some of these dementias that maybe is different. Have you noticed anything like different interests? and activities maybe they've used to enjoy? Have you noticed anything about, are they more hesitant to engage in some of these social activities? Have you noticed any personality changes? Have you noticed them seeming more anxious when they know they've got a doctor's appointment coming up, or anytime you're getting ready to kind of leave the house? So that care partner, or that, proxy, whoever they might be for that individual, is an important part of this piece. And so when we see patients in our clinic, we really kind of insist that they need to bring somebody with them that kind of knows them. And in the case where, like, adult child is working, or maybe they really don't have anyone in their life, sometimes we'll have the person's neighbor or social worker come in, if maybe they've connected in with a clinic or other type of resource in the community, or we'll do a phone call if we really have to try to obtain some of this information. And we all know there are folks that are incredibly isolated out there, where there may not be a real good kind of person to speak to this, but as much as we can, we really try to incorporate that. That's a big piece of the picture that tells us a lot about what's going on there. And then, of course, the review of medical history. So talking about other kinds of conditions they've had going on, what hospitalizations have they had? Is there, any history of kind of major falls or head injuries? And then, of course, the lab work. We want to make sure we do lab work so we can rule out anything that could be reversible, that could otherwise explain what's going on. But I won't belabor this point too much, because I do think we've all had, any of us that have had interest in dementia or Alzheimer's disease have probably scanned to find out a little bit about what increases our risk. We want to know what we can do to prevent our risk and potentially reduce the likelihood. And there are factors that can increase our risk for dementia. Probably the big one we get asked about a lot is just family history and genetics, in terms of, can that potentially increase my risk? And it can. If you have a family member with Alzheimer's disease or another related dementia, it can increase your risk. A lot of folks would estimate that that's typically only about 10 to 15% increased risk, unless you have a true kind of genetic component, like younger onset has a more genetic component associated with it. But for the average kind of person, they had maybe a parent or a grandparent with Alzheimer's disease, you're probably only looking at about a 10 to 15% increased risk. It's really maybe more of the lifestyle factors is what the research is suggesting. So things like how active you are, how well you're sleeping, how stressed out you are you a smoker? Had you eat a healthy diet? These factors may play a larger role in terms of the onset and at what age you experience onset than really necessarily just your genetic history. And as we know, there's a lot of research looking at the relationship between things like hypertension, blood diabetes, and kind of trying to understand why there's some increased risk there. Here are, this is a tool that we have available that we often reference at our geriatric gateway clinic. So this is something you can actually obtain and share with folks. It's aging.slu.edu. But this is all kind of the different things that could be reversible, that could also explain what's going on with that cognition issue. So as you can see, it's, as a social worker going out and seeing somebody in the home, it's really not appropriate for me to give somebody a diagnosis without us being able to look at more of the medical side of things, get some lab work, so that we can really make sense of what all is really happening here, and what other kind of components could be helping to explain the behaviors or the symptoms that we're seeing in an individual that might suggest there's some dementia there. I will say, given that we have 6 million people over the age of 65 with some type of dementia, a lot of times it is dementia, but it doesn't mean that we shouldn't rule out all the other possible explanations and really ensure it's not something where, if maybe we increased, a vitamin deficiency issue, they may have a reduction in some of those cognitive challenges they've been experiencing. I know Dr. Heiner already spoke a little bit about determining between delirium and dementia, and so I just wanted to offer just a brief reminder of the side-by-side of what those look like and how those are different. But obviously delirium begins suddenly, develops quickly. It has a defined starting point. It's not just something that you've just kind of noticed for forever in an individual. And the individual, a big kind of defining component is that the individual typically has difficulty paying attention. They have difficulty engaging, whereas somebody with dementia, they are having more issues with difficulty recalling, difficulty remembering. It's a much more gradual process. And oftentimes folks can't really define a certain starting point. And so with delirium, that's something we want to have folks hospitalized for, and that's something that's ultimately temporary and reversible. So it's important to be on the lookout for that and just kind of differentiate. This is a really nice table that I found in a recently published web article that I've got it listed in my references for folks that just kind of breaks down some of the different components within across some of these major types of dementia, from everything from age of onset to what to expect with progression, and what some of the symptoms kind of look like. And then as I imagine we'll get into with Dr. Lane's presentation a little later today, looking at kind of the pathology and some of the imaging differences across some of these different types of dementia. Alzheimer's disease, I think the hallmark component is really that memory problem. That short-term memory in particular tends to be kind of the first real symptom a lot of folks will see within a individual they're concerned about. Whereas frontotemporal dementia, we tend to see more kind of issues with reasoning and judgment, sometimes more personality changes. So a lot of the folks that I see will get referrals, they're started having real issues with managing their money. They've really fallen, susceptible to a scam. They may have developed a gambling addiction out of nowhere, or sometimes even extreme things like they've been arrested for shoplifting. And that's just so different from what maybe a family member has been used to seeing for that individual. Lewy body dementia oftentimes I think gets overlapped a lot with Parkinson's in terms of some of the symptoms that they see. But hallucinations, delusions are much more prevalent with folks that are experiencing Lewy body, much more likely to have some issues with sleep disorder. And their mobility looks very different in terms of how they walk. Folks describe how they turn kind of funny. And so those will be common things that we'll hear from families when we're talking with folks and they have some concerns about their loved one. And then finally, vascular dementia. Of all of the dementias, this one tends to be can be more abrupt. And that is often because of what causes vascular dementia. There's many types of vascular dementia. But the big ones that we frequently see are folks that may experience a stroke or a series of mini strokes. And that kind of defines some of the cognition changes that they experience, the memory changes that they experience. So I'll leave that for now, as I know we're going to come back and talk more about differential diagnosis later. But let's talk just briefly about the interdisciplinary team before we get into some of the different cognitive screenings that are out there. So I would wager that the average person is probably not going to see all of these professions, regardless of what medical system that they encounter with. I think what folks get access to greatly depends upon kind of the organizational structure. So, for example, I prior to coming to SLU, I was with University of Kentucky's Alzheimer's Disease Research Center. And so for the clients that we saw, a lot of them were engaged with their primary care doctor, of course, the neurologist, and then they also had access to social workers and occupational therapists. And that was who was on our team. We didn't have a lot of nursing. We didn't have neuropsychiatrists. We could make referrals to speech and hearing because they were at the university. But they weren't encountering kind of all of these kind of diverse team members and what everyone could kind of offer for them. And so because of that, there may be things that folks got really great treatment for, maybe not so much, or we may have to really go out of our way to kind of try to link them in with a particular referral. If we really thought, man, physical therapy would really benefit this patient, let's figure out how to get them access to that. That's not something that we currently provide within our system. So how can we really link them in with that? Primary care doctor for most folks is something that a lot of folks have access to. Some of the folks I see with my live alone population don't necessarily see a primary care doctor. They might go to a clinic or they may not have been to a doctor in decades. But we try to link them in, get them started with somebody seeing them kind of more regularly. Those primary care doctors tend to be kind of the central point of contact for patients and are ultimately, in a traditional model, who is kind of coordinating care. So obviously ADRC, we're very research centric. So a lot of what we're linking folks in and connecting them with is partly because they're engaged in research and usually pharmacological trials. But in a traditional patient that just goes into the doctor and expresses concerns, that's probably going to be mostly coordinated by a primary care doctor, and they're going to be the ones that are maybe initiating some cognitive screening, helping to maybe link the patient in, make a referral to a neurologist or a neuropsychiatrist. Neurologists are often involved in more of the diagnostic process, particularly in cases where the cause of dementia is unclear, or if there's a need to want to make a real differential diagnosis. And so they're going to be much more likely to order some neurological evaluations, some detailed assessments of what's going on, and understanding some of the cognition. And they're going to probably order some neural imaging. So this could be things like MRIs or CT scans. PET scans are fabulous, but they're not always available to folks, depending on what neuroimaging devices are available, or even what insurance will reimburse for. And then they a lot of times will help to identify the specific differential diagnosis. Is this Lewy body? Is this Alzheimer's? They often are kind of key in terms of making that clarification. Geriatricians, as we've heard already a bit from Dr. Heiner, are also can offer those comprehensive assessments, some differential diagnosis, and tend to be very involved in some of the treatment and planning for individuals once they have that diagnosis. And neuropsychiatrists, I think, work a lot of times in conjunction with brain imaging. They also can do some of these more comprehensive assessments around cognition and function. And they can also, I think, really hone in on some of those behavioral concerns that sometimes families may experience that tend to be sometimes more prevalent with certain types of dementia. So a neuropsychiatrist would especially be really helpful if an individual is experiencing a lot of behavioral disturbances that are distressing to the individual or their primary care provider. And so they can help to not only make suggestions in terms of interventions that the individuals can do with care, but they can also prescribe medications that may help to lessen some of those symptoms if they're causing distress for the individual. Now, obviously, we don't want to treat symptoms if they're not causing distress for folks. That can lead to overprescribing and overstress, honestly, for care partners. But as much as we can to kind of ensure that we're setting folks up to be able to continue to be safe and have their support needed, we want to be able to do that. Social workers, again, can help with cognitive screenings and assessment. They can also work to do some advanced support planning. I don't have nursing on here, but they also can offer a lot of those same kind of overlapping supports as well. Caregivers will help with emotional support and counseling. They'll help to do caregiver education and support and advanced care planning. And then social workers are often also used to help with crisis intervention. So if we're talking about an individual that's having really distressing behavioral disturbances, where they maybe are even threatening their care partner or becoming more violent, a social worker can work with them to talk about some conflict resolution. Occupational therapists, which I think historically have been less used in the dementia care team, but are a valuable resource, really help to kind of focus on maximizing the patient's independence and autonomy and improving their quality of life. And so they may be able to offer some therapeutic interventions that help to reduce some of the behavioral symptoms and also address some environmental modifications. So they can talk about, if an individual is really having a lot of anxiety, high stress, what are some things we can do in the environment to kind of alter that for them? Could we, turn on the lights? Could we reduce some of the noise? Could we stimulate them with some sensory types of items. So occupational therapists have some great expertise that can ultimately kind of support some of that, especially with behavioral management. And they also can work with a family to potentially reintegrate an individual back into the community for some more kind of socialization and engagement. Physical therapists do more kind of a functional assessment. So they oftentimes will help an individual with some things like fall prevention, mobility, helping folks to be able to maintain that independence and getting around. They'll also work on things like pain management, ensuring that if an individual's, maybe they've got really bad arthritis or they've recovering from a broken hip, how can they maybe work to kind of address some of that? They also offer a lot in terms of environmental adaptation and as well as education and support for those that are providing care. And then lastly, speech and hearing therapists often will conduct a communication assessment. They can work to offer language therapy, and that can be especially meaningful for folks that are experiencing aphasia. They often can help to address speech production difficulties, and they may also be able to assist if there's some issues happening related to swallowing. If an individual is starting to have more difficulty with that, they can offer some techniques and strategies that somebody who is assisting with care can help to implement for the individual, as well as alternative communication strategies. So the use of visual aids, verbal, how we can maybe change the verbal instructions, the nonverbal instructions, those pieces to kind of help and support that, especially as somebody starts to become more impaired and lose more of their speech. I see there's some questions in the chat. I'll be happy to chat more about that when we get to the end here. So let's just talk briefly about some of these cognitive assessment tools. I recently attended a training where they were talking about the mini mental status exam, or the MMSE, and they just had a tombstone over the slide. And I thought that is so appropriate because the MMSE has really gone out of favor in terms of being a screening tool that folks are utilizing, not only in the research aspect, but also in the healthcare setting. It is a good instrument in the sense that it covers a wide range of kind of some of the different cognitive domains that are appropriate with dementia. It's quick to administer, it takes 10 to 15 minutes. But it, as previously mentioned by Dr. Heiner, it is just not very strong in terms of its ability to pick up in terms of folks that are kind of earlier along in the process. So it doesn't do a good job of detecting MCI. It also is not very useful in looking at change longitudinally. And so a lot of folks have really moved away from using the MMSE, but it is still a tool that's out there, and it's probably the one that most folks are most familiar with. It's got that name recognition that I think folks have heard of it before. It's maybe something they learned about it in their training, and they have some familiarity with it. So here's what kind of the MMSE entails. Spell world backwards, orientation to time and place, registration, can you repeat these 3 words? And of course, that visual spatial skill, copying simple figures. So MMSE is available. There is typically a cost to utilize it. And with all of these assessments, I guess I didn't start by saying this, you really should have some specialized training before you're really kind of common practice administering these. And most of these assessment developers have provided some type of training on their website, or when you go to kind of purchase the tool, they'll offer some things like that. So another tool that is becoming much more commonly used, and one I use a lot within my own research, is the Montreal Cognitive Assessment, or the MoCA. And so similarly to the MMSE, it assesses various cognitive domains. And it seems to be a little bit better at picking up on sensitivity, especially among folks that are kind of in the earlier stages of the disease. Now that we're getting better at diagnosing folks earlier and earlier in the disease process, folks are getting diagnosed early stage as opposed to kind of more middle, late stages. The MoCA has become a really useful tool in helping to kind of be maybe what is initially catching folks in terms of recognizing there's a concern here and we need some additional testing and support. This one is also only 10 to 15 minutes to administer. It's 30 minutes. For permissions and certifications, you can go to mochacognition.com to learn and train more on the MOCA test. I believe this training is about 3 hours. I send a lot of my students through it because it's free for students to complete the training. It is also free for folks that are using it for research purposes to use for training. However, I think there are additional kind of permissions and purchasing that has to happen should you use it for your research. But it does include some of the MOCA or some of the components we've already even hinted at with the trail making test B, clock drawing. So it's incorporating some of these different known components. It asks folks to name animals. Can they do, recall, serial subtraction, some repetition, and then of course the orientation. Do they know kind of the date and location of where they're located? And so I think in terms of utilization, I would guess the MOCA is probably the one that's being most used these days. However, I'd be interested to see if maybe there's a study that can confirm that. Maybe a meta-analysis or something. Another test that is frequently used and oftentimes kind of a component of some of these other screening tools we're talking about is the clock drawing test. So for those of you that may not already be familiar with the clock drawing test, this is a widely used screening tool for assessing cognitive function. And it really focuses on testing executive function and visual spatial abilities. What's nice about this test is that it can be administered pretty quickly in about 5 minutes. And it is more challenging to do remotely. It is a good tool when you're face-to-face with an individual. I do know there are folks running some studies right now looking at doing the clock drawing test virtually, being able to use it remotely. But as you can imagine, since we're asking folks to physically draw something, that can be really challenging to be able to kind of watch it. You kind of have to have them like hold up their paper to be able to really see what's going on and be able to assess it. But essentially, the clock drawing test is asking folks to draw a clock face and then put in the numbers and settings on the hand, typically 10 minutes past 11. And then there are various different scoring methods that can guide you in terms of how do you kind of assess, is this correct, is this not correct? There are some methods that exclusively say everything has to be perfect. All the numbers have to be equally spaced. The hands have to be drawn correctly and at the right time in order to acknowledge that somebody did well versus if there's a concern about cognition. There's others that tend to kind of, oh, you got some points because you did get all the numbers, even if they're not quite spaced the same way. So in determining how you're going to assess that, you need to consider some of the different criteria that in terms of how to evaluate. And so if you're using the MOCA, which uses the clock drawing test, they give you very specific instructions about how they want you to score the clock drawing test. Same thing with slums. We give very specific criteria on how we want you to score it in terms of kind of understanding. So here's some just some examples of some variations for what those clock drawings could look like. You can see, with criteria that it has to be exact. I would argue A, B, and C are definitely not appropriate, whereas D, you probably wouldn't deduct any points on that cognitive screening. That is pretty solid in terms of being fairly close to exact, whereas other scoring methods might say D is the numbers aren't quite spaced appropriately, and I would say that looks pretty good. As a comment, I think it's going to be so interesting with this younger generation that's coming up with clock drawing. My kids can't read a clock like that. They just know digital. They can only, it's 4.30. They don't look at clocks and read them, I think, in the same way that we're used to because of this technological era and cell phones and whatnot. So those of you that are interested in research, please get on that and think about how we can assess that a little differently going forward. I think that's going to be a need with future generations on these cognitive screenings. Almost finished, 3 more left. I'm going to just briefly kind of go over, and then we'll have some time, I think, to tackle some questions. Clinical dementia rating, or the CDR, is probably the instrument that's used most frequently in research settings. There tends to be a real value to the CDR and its process. That is absolutely what we were using in our ADRC for all patients as part of, those that are involved in research and trials. It is a semi-structured interview that needs to have a patient and an informant. And again, even if that informant component has to take place over the phone, an informant has to be involved in the process. And it does take about 40 to 60 minutes to administer. This instrument was developed by Washington University's in St. Louis's Knights ADRC. And there is very specific training folks have to undergo in order to be kind of granted permission to use this tool. And I do believe there is a fee to be able to use it, especially for research purposes. The CDR does include, those typical cognitive domains that we've seen in other places, but it also includes components like community affairs, home and hobbies, asking folks about personal care. So here you're really getting kind of a cognitive and functional, and even a little bit of a social kind of component for folks. And so with CDR scoring, this is most frequently used in conjunction with lab work and brain imaging as terms of kind of how we interpret the results. But the scoring uses kind of that de facto criteria with, 0, there's no impairment, 0.5, very mild, 1 is mild, 2 is moderate, and 3 is severe. And so in terms of kind of guessing kind of the progression of where folks are in the disease process, this can allow us to kind of gauge kind of where they are in that trajectory and thinking about what's maybe coming and what maybe some of the current challenges are that an individual is experiencing. So here's an example of kind of the CDR screening visit and what some of those components look like. So again, this was the tool that we used most frequently for our pharmacological studies. The Functional Assessment Staging Test, or FAST, is an instrument that's kind of more associated with functional abilities, but I think it's important for folks, if you haven't heard of FAST before, just to be familiar with it. It is a 7-stage kind of cognitive test across kind of functional decline, and it's often used most frequently as part of hospice admission assessment. So it's something that, at least if you haven't heard of before, it's good to at least have on your radar. You can learn more about it at the mmcare.com link at the bottom. But again, it is a semi-structured interview for the patient and an informant. It can take up to 30 minutes to administer, but it does give you a good idea in terms of some of the functional challenges an individual is experiencing, particularly within the context of their activities of daily living. And again, it's very frequently used as part of hospice admission. So the last cognitive screening I'm going to talk about today, of course, St. Louis University, I have to talk about the slums. This is an instrument that is very similar to the MMSE, the MOCA. It has a lot of the same components. It's got the clock drawing test. And it was developed and tested for reliability and validity to really kind of assess the cognitive screening for folks of various types of dementia. And it does do a really good job of identifying mild cognitive impairment. There is some research that suggests it is the best instrument for identifying mild cognitive impairment, but I'm sure we, of course, could always debate that. It is typically kind of normed for folks 60 and older. And so it may be less useful if you're testing it with somebody who has younger onset. However, we could also make that same argument for, I think, most of these tools that were developed really for folks in older adulthood. We offer training on the slums on our website for free. This is the only instrument that I'm aware of for cognitive assessment that you can use in practice or research without having to pay for training or for utilization. It is a fully free document. We just ask that you acknowledge it by, obviously, its name for copyright purposes. And it essentially asks a number of the same kind of cognitive screening tests. So what day of the week is it? What is the year? What state are we in? Some different kind of math problems. We ask folks within a 60-minute time frame to name as many animals as they can. If you go through the training, it'll help to clarify for folks that you really shouldn't be counting if somebody's just naming off different types of birds. That shouldn't count as distinct animals. You really need to kind of define by birds, and then other types of animals, as opposed to saying cardinals, pelicans. That's not what we're looking for on that specific assessment. So that's why, again, training is so important. It really guides you in terms of what can you count, what can you not count, how can I maybe adapt to this a bit if it's appropriate. I really struggled when I was first doing cognitive assessments to not, you want to give people feedback, right? They answer some of these questions and they're kind of looking for you for reassurance or to tell them they're correct or what. And the test would really guide you that you're really supposed to be kind of really straightforward in going through the questions and not soliciting a lot of feedback or trying to help the individual. And so, again, if you haven't done some of these trainings before and you're going to do some cognitive screenings, I'd really encourage you to go through the training with them. We do have the clock drawing test on here. And we do give a story. I think there was a question in the comment earlier about how do we handle when an individual may not be from the United States. And here we are asking them questions about Chicago and what state that's in. We do have this tool has been tested in a number of different languages. A huge number of different languages are available. I'm sorry, I don't know the exact number right here, but it has been adapted in that way. And we also do make sometimes real-time adaptions. But we have to, I guess the biggest note I'll make about that is that you have to make note of that. So if you had to make an adaptation, a cultural adaptation, especially on the spot, sometimes we'll have folks come into our clinic and we don't know that they're from Cameroon until they get there. And so, we can get an interpreter on the phone pretty quickly, but sometimes we have to make decisions. And so we really train not only our staff that are going to be administering these, but also the students that are working with us on what that looks like and how to do that. And so we may change some of the items in the meeting. If we're asking them as part of their speech language assessment to name the each of these items. Sometimes we'll change them to things that we know that they already have familiarity with because they've talked about it. And then we make a note of it as part of the assessment. And so is that a limitation? Absolutely. But it's something that we need to make sure is clear so that when they get that referral to go see, the next step of the cognitive diagnosis process, that they know that coming into that they're, our score may need to be adjusted a bit because of some of those factors. A lot of these screening instruments do give guidance about, if somebody has less than a high school education or less than an 8th grade education, here's how you should adjust the scoring. And the SLUMS does make that recommendation for folks. And I think that's a good thing, but we also know, right, that is not a hard and fast, always going to be accurate truth. And so, again, this is just a screening. It's meant to potentially promote, let's do some additional cognitive testing here. And so that's kind of how we operate and look at that. Here, example of some of the training videos we have. All of these are available to download through aging.slu.edu. And we do offer one even more abbreviated test. It's the Geriatric Rapid Assessment. It's only 5 questions. So if you are maybe just wanting to gauge right off the bat of a meeting, kind of where folks are, or if you're out in the community and it's not your primary goal, but you at least want to kind of check in to see how their cognition is doing, this is a nice one that kind of helps folks with some of that. I want to get to questions, so I think I'm going to jump ahead, but I think these slides are going to be shared. Is that correct? Folks will be able to come back to that. Thank you. Perfect. So please do come back. But this is just a guidance in terms of how we talk about brain health and how we communicate results to folks. We didn't, even though the cutoff scores will say this is mild cognitive impairment, this is dementia, we don't necessarily come in and tell folks, hey, you have dementia, like there's this is what this is. We'll often come in and say, hey, this is what your score is. What we would recommend at this point is that it's necessary to continue to get some additional testing and consultation. Here's some information about, brain health and proactive things you can do given what some of the information resulted in. However, note that some of this, these results could be reversible. And so that's why it's really important that we get you connected back in with the doctor. We do some additional lab work. We try to rule out other explanations for what could be reversible reasons that we're seeing some issues with your cognition. And then, of course, there are, just as a reminder, got to leave folks on a positive empowerment. What can they do in their situation? So they do find out they have dementia. They do find out it's actually vascular dementia. I'm devastated. I'm a bit in denial. What else can we do for folks? There are many modifiable lifestyle factors that, as far as our evidence can tell, suggest there could be some things folks could proactively do related to how they're eating, how they're, staying active. They need to stay social. We've seen so much data as the result of COVID-19 coming back and suggesting that isolation and loneliness really impacts folks. And so we want to get folks engaged with others, get them socializing, get them peer support. We offer a program through SLU called Cognitive Stimulation Therapy. It is an evidence-based or evidence-informed, I guess I should say. We can't really pursue the evidence-based classification right now, given how they're reviewing those classifications. But it's an evidence-informed intervention for folks to help them kind of improve their memory, and it also helps them in a number of the cognitive domains that often are experienced with decline as part of this diagnosis. Ultimately, folks will continue to decline until we have a cure for this disease, but we try to keep folks as high functioning for as long as possible, and that's why getting folks engaged with things is so important. Alzheimer's Association has a 24/7 helpline. There's many community-based programs out there, many that are even online now if folks don't live close to a lot of resources. And then, of course, want to talk about safety with things like, medical alert, safe return if folks are wandering, or there's a concern that an individual may get disoriented and not be able to get to where they need to go. And we also talk about safety with things like driving, guns, and their financials.